So, good afternoon, ladies and gentlemen. Now we are open our the session Medical Retina Symposium 3, and we have 1 hour duration, and we have uh, five speakers in this session. Me and my co-chair, Dr. Tengku Erin Kamelden from Malaysia, will moderate this session. And we start with the first speakers, Dr. Jose Gerardo Garcia, and will speak about effect on the ocular surface of 5 versus 1% povidone iodine for intravitreal injection. Okay, doctor.
Good. Well, good afternoon, everybody. So this is a study that tried to, as the title suggests, to compare the impact on the ocular surface between two concentrations of povidone iodine. And the rationale being that most of us are using 5% povidone iodine, since that's the concentration that's used in surgery. Um, these are my financial disclosures. So we are very fortunate that this procedure that we perform super frequently has very low risk. So fortunately, endophthalmitis risk is very low with the current practices that we have, and these practices include, I believe, in most of the world, the usage of 5% povidone iodine as a topical antiseptic. Now, although this concentration is generally well tolerated, it can be associated with ocular side effects, corneal epitheliopathy, contact dermatitis after repeated exposure, and patient discomfort immediately, which can linger for hours or go even into days. And if you work in a very high volume setting with a lot of injections, it is not uncommon for patients to call you or call your clinic because they are feeling the eye is red, they are feeling a foreign body sensation, etc. Now, other alternatives beside 5% povidone iodine have been explored, one of them being aqueous chlorhexidine, and also lower concentrations of povidone iodine. Now, there are some papers talking about this, and one of these is this one. It's a multivariable analysis based on injection protocol and povidone iodine strength, and this found no difference between 10%, which is like the stock, the one that you get like in the pharmacy, and 5%, which is the one that we all use. And there are other papers that have tried different concentrations, and they have proven that lower concentrations maintain safety to 2.5%, 1.25%, or even 0.625%, while retaining efficacy. Now, why is this? The thing is, povidone iodine works in a different way than when we're using an antibiotic, for example, or chlorhexidine, which is another antiseptic. In this case, povidone iodine, the povidone molecule is a transporter for free iodine. So when it comes in contact with water, it releases the free iodine, which is the one thing that does the actual killing of the bacteria. So up to a certain point, when you dilute povidone iodine, you have more free iodine, although you have a lower concentration, right? And this was proven in the 1980s, as you can see in this table. These are the different concentrations, started with 10%, going down to 5, 2.5, 1, 0.2, etc. And you can see the 5% that we are using, even up to 1 minute, you can still recover some bacteria, while lower concentrations, in this case 1%, bacteria are killed almost immediately, and at 15 seconds you have no bacteria in this in vitro study. And this is how it works. So here, remember, what does the actual killing of the bacteria is the free iodine. You have 5% iodine with very low concentration of free iodine, less than 5 parts per million, while 1% actually has more than 10. So that is the reason why 1% povidone iodine kills faster than the 5% that we're used to. So the aim of this study was to compare the effect of these two different concentrations, 1 versus 5%, on the integrity of the ocular surface and symptomatology of patients undergoing anti-VEGF intravitreal injections. We developed this prospective randomized controlled trial and included patients over 45 years that underwent anti-VEGF intravitreal injection. And we excluded, obviously, patients that had severe dry eye syndrome, diagnosed previously, idiopathies, or other factors that could affect the state of the ocular surface. So patients were randomized to receive one of these two concentrations, and the ocular surface was evaluated prior to the intravitreal injection application and 15 minutes after. Now, the evaluation was, to make it more objective, was done with this device, the Oculus Keratograph 5M topograph. And we analyzed three different characteristics of the ocular surface. One is the non-invasive keratograph breakup time of the tear film, called the NICBUT, the bulbar conjunctival hyperemia, and the ocular surface fluorescein staining using the Oxford grading scale. Also, patients were asked subjectively about the ocular burning sensation they experienced after 48 hours of having the injection in a scale from 0 to 10. These are the three parameters. So as you can see, by using these placido rings, the tear breakup time is somehow calculated. Also, the bulbar conjunctival hyperemia and the ocular surface fluorescein stain. These are just some examples of each. So as you can see, before the injection on the left, the placido rings are very, very regular. And after the injection, you can see that the placido rings become more like distorted. And this is analyzed by a computer showing in the orange and red squares or areas the way that the tear film is affected. This is an example of conjunctival hyperemia. And as you can see, the image on the left is before injection, so there is not a lot of hyperemia. And the image on the right, you can see hyperemia has increased. And this is assigned a numeric value. In this case, it's 1.3 or 2.7. And this is the fluorescein staining. And in the left, you can see that there is practically no fluorescein staining, while the image on the right has a lot of fluorescein staining after the injection. Now, what were our results? We included, as I said, 98 patients. 51% had a 1% solution. 47 had a 5% solution. There was no difference between the baseline characteristics. And when comparing in both groups, when comparing the pre-injection characteristics versus the post, all values were different. So all patients had shorter breakup times after the injection, more conjunctival hyperemia, and more staining, but there was no difference between the 5% and the 1%. However, when asking subjectively to the patients about the ocular burning sensation, which is the graph on the left, the 1% had significantly less complaints about the ocular surface when compared with the 5%. So in conclusion, all patients developed reduced NICBUT, the tear breakup time, and increased conjunctival hyperemia and fluorescent staining after the procedure. Overall, the ocular surface side effects objectively measured were very similar between both groups, with no significant difference. And even if the ocular surface side effects were present in both groups, the ocular burning sensation in the 1% group was significantly lower than in the 5% group. We couldn't explain it with the three variables that we measured, and there were no cases of endophthalmitis in either group. Obviously, this study was not powered to evaluate a difference in the incidence of endophthalmitis. So the take-home message here is that povidone iodine at 1% in intravitreal injections causes less subjective discomfort compared to 5%, although the ocular surface disturbances appear to be similar between both groups when measured by the Oculus keratograph. Because of what I've shown, that the 1% solution is actually quicker in killing bacteria, I have, since maybe a couple of years, implemented using 1% povidone iodine before injections, and I have found that the efficacy is the same, and I have a lot less complaints regarding the ocular surface. And thank you for your very kind attention.
Thank you, Dr. Garcia. This is excellent study. So we learned that 1% is even better than 5%. So do you suggest, with this logic, do you suggest 1% povidone iodine for regular operations.
Yeah.
Why not is 10% or 5%? Do you
that
suggest this one?
yes.
There's any scientific data support this
Well,
suggestion?
it hasn't been done.
Because we still use 10%.
Yes. Oh,
Everywhere.
10%?
Yeah.
Oh, well, in the US and in Mexico, we use 5%. And I think this is one of those examples that we do it because it has always been done that way. That is one. So we do it for surgery. Then we just transpolate it to the injections, and because everybody does it that way, then we keep on doing it, and regardless of if the patient has pain or whatever. And the other factor that I have found is that most of the people don't know, and I didn't know before I started doing these studies. Tomorrow I'm going to talk about povidone iodine infusion during vitrectomy for endophthalmitis. In the BSS bottle, I inject povidone iodine at a concentration that's safe and effective. And one of the things that I have found is that most of us, even though we use povidone iodine every day, we don't really know how it works. We think it works as a regular antiseptic, as if you're using chlorhexidine or alcohol or any antibiotic. The more you dilute it, the less concentration you're going to have. This works in a different way. The more you dilute it up to 0.1%, you're going to get more effective while you dilute it, and then it's going to the efficacy is going to go down.
It's very nice. So the other things, some patient has allergic reaction for povidone iodine. Do you have an experience with chlorhexidine for these patients?
So one of the things, after reading a lot regarding this topic, doing the review, true allergy to povidone iodine is super, super rare.
Right.
So because in the end, you cannot be allergic to an element in the periodic table, right? So the free iodine, you cannot be allergic to it. You need iodine to produce the thyroid hormone, etc. So true allergy is really, really rare. Most of people that say that are allergic to iodine is because they had some intravenous contrast for X-ray imaging studies, and they were allergic to those media. True allergy, but it has been described. So in this case, I think chlorhexidine is a better option than keep using povidone iodine.
Okay, very nice. Any question from audience? From my co-chairs? Okay, thank you.
Okay, we're done.
Thank you.
I will be moving to the surgical retina discussion. Thank you very much.
Welcome.
Right, our next speaker is our chairman himself, Professor Ramzi Afzi. He'll be talking on the current management of diabetic retinopathy. What is the gold standard, discussing laser versus anti-VEGF.
Thank you. So, dear moderate colleagues, as you know, I will speak about the current treatment after using anti-VEGF, current treatment of proliferative diabetic retinopathies. So these are my financial disclosure, but none of them are related with the content of this presentation. So as you know, panretinal laser photocoagulation is a gold standard treatment for over 45 years. And we all have numerous cases, as you see in this picture, that remain stable for many years after completing PRP, even also reduced the number of visits almost once a year. However, recently, peripheral visual field loss became controversial after anti-VEGF injections. So anti-VEGF treatment not only stopped the progression, but also improved the diabetic retinopathy if we use a regularly injection, as you see in the slides. The slide is from Ramin Tadayoni's archives. So recently there are two studies compare the results of PRP and anti-VEGF injection. It's Protocol S and Clarities. The Protocol S study published the 5-year results and they compare PRP with ranibizumab injection in PDR cases. And when we look at the first 2 years, the difference is clear. Anti-VEGF injection is significantly better compared to PRP about the visual gain. However, when we look at the 5 years, there is no difference between these two treatments. So about the number of injection in ranibizumab group is almost 20 injection in these 5 years, but on the other group PRP is only 5.4 injection, and in PRP group anti-VEGF was administered only in case with concomitant diabetic macular edema. So what about the adverse event in these two groups? So there is no significant difference between two groups in terms of iris neovascularization, vitreous hemorrhage, and also vitrectomy necessities. So when we look at the diabetic retinopathy severity of the fundus photo at 5 years, of course, in anti-VEGF group has significantly better results, and we observe that they observe regression from diabetic PDR to non-PDR is almost 1/3 of the patient, and no diabetic retinopathy in 10% of patients, and two-step regression of diabetic retinopathy severity in almost half of the patients. So these are really extremely good results. So this is the advantage of anti-VEGF treatments. So what about visual field loss? And again, in the first 2 years, there's significant difference between two group, and ranibizumab group is significantly better comparing the PRP group. However, when we look at the 5 years, there's still significance, but there's still difference, but it's not significant. So what's changed? What's changed in 5 years with comparing the 2 years? So we should look at the clarity study also. And also in this study, they published 2-year results, compare aflibercept with a PRP group, and in all these parameters in this study was better in aflibercept group comparing the PRP. However, there is some limitation of this study. Almost 50% of cases receive treatment prior to study, and 77% of the cases have low risk of PDR, such as level 61 and 65, and long-term results are not available because only we have 2 years results. So in summary, it's very clear that VEGF is the main factor triggering neovascularization in PDR, and when we can use anti-VEGF regularly in a regular fashion, we can significantly reduce the severity of diabetic retinopathy. Also, we obtain some improvements. And this in laser group, we usually observe slow reduction of VEGF load, and anti-VEGF we observe fast reductions. So what about the patient who dropped out prematurely from study and did not continue treatment? When we look at this protocol studies, almost 40% of patients in both groups lose the follow-up during 5 years. So there is no data in these patients, and this is, I think, the limitation of protocol S. We don't know what happened the patient who dropped out from the follow-up after 5 years. But there is some studies on the literature that we can find these results, and Obeid et al. Reported the results of follow-up, the patient who lost the follow-up in their study, and they found that during the duration of without follow-up is about almost 1 year in 2 groups. And in anti-VEGF group, they observed neovascularization of the disc is almost 40% of the patient, rubeosis in 13%, and tractional retinal detachment in 1/3 of the population. However, in PRP group, results was perfect. There is no bad progression in this group of patients. So serious complication that treatment vision may occur in patients receive only intravitreal anti-VEGF in case of loss to follow-up. This is very, very important data for us. Why is it important? Because anyway, the other difference between these two treatment groups about the cost. The PRP treatment is much less cheaper compared to anti-VEGF treatment during this 5-year period. So in summary, the advantage of PRP is provide lifelong efficiency and fewer follow-up requirement compared to anti-VEGF, lower cost compared to anti-VEGF, no risk of endophthalmitis and systemic side effects, more stable results in patient loss to follow-up. This is very important. What about disadvantage? Peripheral visual field loss, but this is also controversial. During the 5 years, at the end of 5 years, there is no significant difference between two groups. The advantage of anti-VEGF is lower risk of diabetic macular edema, and occasionally need for PRP and regression in diabetic retinopathy severities. However, disadvantages is far higher cost, risk of endophthalmitis, but the most important one is serious complication in patient lost to follow-up. So, and therefore, you can say that PRP is still a gold standard treatment for proliferative diabetic retinopathy in our daily practice, because even in the trial study, 40% of patients lost to follow-up. In our daily practice, in your practice, and I can say that in my practice, maybe more than 60%, like 70% of patients lost to follow-up during 5 years. If you do not do anti-VEGF injection in this group of patients, this is mean that we can observe very severe retina. During the pandemic, we observed this. The patient lost to follow-up after anti-VEGF, and they return back to our office with very severe diabetic retinopathy progression. So I would like to conclude my presentation with some frequently asked questions. So, does PRP still remain the first-line treatment for patients with newly diagnosed PDR? The answer is, regarding the high cost of anti-VEGF and loss to follow-up rates, PRP remains the gold standard treatment. But except case complicated with DME, vitreous hemorrhage, neovascular glaucoma, anti-VEGF prior to PRP could be beneficial in this group of patients. The other question is, what are the key points while performing PRP? Which point we should take care? So we should avoid insufficient treatment, because insufficient treatment may cause neovascularization and vitreous hemorrhage, but over-treatment may cause visual field loss. But I think insufficient treatment is far more dangerous than over-treatment, and therefore the most important cause of vitrectomy necessity is insufficient treatment, and therefore we should apply enough laser in this patient when we start with the PRP. Other question is it appropriate to perform selective laser rather than conventional PRP, like fluorescein angiography assisted laser for ischemic area solely? So there is no, this is controversial. There is no strong evidence, but visual production continue in other areas also, like, for example, in this patient, not only this area, but this area also reduce some vessel densities, and therefore visual production also is continuing there, and therefore conventional PRP should remain the treatment of choice today with our evidence. So the other question is, we can also see hemorrhage in adequate PRP and stable retina after completing the PRP. As you see in the slides, we can see this, and we say that everything is okay, retina is quiet, but still there's hemorrhage. So how should we approach in this case? Should we do additional treatment? I think in this group of patients, it's not always a sign of activation, the hemorrhage, because hemorrhage can also occur when there is traction at the vitreoretinal interface. And therefore, in this patient, we should check the vitreoretinal interface with ultrasonography and OCT if there is vitreoretinal traction. And maybe vitrectomy could be more appropriate option than PRP if the main cause is active traction on the retina. So the traction also may cause hemorrhage. So in conclusion, VEGF is a key mediator of pathological angiogenesis, and anti-VEGF is at least as effective as PRP in short term and might be the first line treatment for patients with DME, and in combination with PRP also we can use, but PRP still remains the gold standard therapy for proliferative diabetic retinopathy case. At least in my practice, I still follow the PRP regulation to treat this patient. Thank you.
Thank you very much, Professor. Are there any questions from the floor? Yes.
So the question is the combination. What about the combination treatments? Because your loud is very low and the audience couldn't hear. So yes, I agree. We can apply combination treatment, but the point is that we should not leave PRP in this group of patients. We can combine, if there is, especially in patients with diabetic macular edema, you can combine these two techniques, but PRP is still that we should continue to do in this group of patients. So in this patient, I practice, I do not apply anti-VEGF injection, even especially in patients with higher visual acuities, like more than 20/50s. So I start directly with PRP, if some complications are like macular edema develop at the anti-VEGF injection, because it's not explained always to patient who has a very good visual acuity to do the injection into the eye, and therefore I prefer PRP. Then, if necessary, I inject at the anti-VEGF injections. Okay. Yeah. You mean in patient with proliferative diabetic retinopathy and macular edema, can we combine these two treatments? I have no experience with subthreshold laser treatment on macular edema, but if we have anti-VEGF, we know it's much more effective than subthreshold laser for the macular edema, and therefore I think we should prefer anti-VEGF and PRP instead of subthreshold treatment. The effect of subthreshold treatment is very low in this patient. But the other things that maybe we can point out at, we have recently pattern laser, and the pattern laser also we should take care about the intensity of laser, and the severity, the intensity of pattern laser, and after pattern laser, the regression of the neovascularization, the regression of the severity of diabetic retinopathy is much less compared to PRP, the argon, the standard PRP. And therefore, in pattern laser, if I do pattern laser, I apply more intense laser, more close to laser spot. For example, in argon laser, we used to use one spot, one separate size of the separate, but in pattern laser, I reduce the separation area is like half of diameter of the spot. So more intense laser we should do. Okay. So we don't know the answer of this question. Nobody knows. We never can say that this laser is sufficient. When we saw this after pandemic, and we have many cases, and everything is stable and very stable retina, very inactive diabetic retinopathy. But a year or one and a half year later, after this loss of follow-up, patient come with hemorrhage. So still we don't know the answer of these questions. And but as I mentioned, not all case is because of the diabetic severity. Some hemorrhage can be because of the tractions. We should separate this, but still we don't know what's the dosage and how the pan-retinal PRP is enough to do, and we don't know. It depends the patient's position. Between injection, anti-VEGF, you mean? Actually, I use aflibercept in my practice. Aflibercept. I don't have any comparative results, but I think it's almost equal results that we obtain with ranibizumab, aflibercept, even bevacizumab. Not big difference. You can use all of them. Sure, it's also good options. Okay, thank you.
Thank you, Dr. Remzi, for a very informative lecture. Do we have Dr. Ali Haider with us? Okay. Dr. Rahman Siddiqui is around? No. Dr. Mariam Shamim. Thank you. I would like to invite Dr. Mariam Shamim. She would be talking about subthreshold laser for CSCR, a non-damaging treatment option. Thank you.
Assalamu alaikum. My name is Dr. Mariam Shamim, and I'm here representing my hospital, specifically the medical retina department of my hospital, that is LRBT Eye Hospital, Karachi. The topic of my treatment today, of my presentation today, is subthreshold laser in the patient of CSCR. That is a promising and non-damaging option. So first of all, I would like to move on to my cases. The first case is of a 40-year-old male who presented with blurring of vision for 4 months, and the presenting best corrected visual acuity was 624, and he was using topical naproxen. These are the OCT scans of the patient. Another case of a 42-year-old male, he presented with 636, and he had a history of CSCR for 6 months. He had a history of using oral rifampicin and topical naproxen. These are the OCT scans. Another case was of a 55-year-old male. He had a long history of decreased vision. His vision was counting finger. He also had a history of using anti-VEGF in the eye, and there was a small PED associated with the CSCR. So we all know what CSCR is. It is basically a neurosensory detachment at the macula that is basically due to a damaged or diseased RPE and leaky choriocapillaries. It is fourth most common non-surgical maculopathy, but still now we have no treatment guidelines available. So there are some options that we all use. There is laser, there is glucocorticoid, mineralocorticoid antagonist, there is PDT with half fluence or half dose, and also there is intravitreal anti-VEGF. So for our treatment, we chose subthreshold micropulse laser. That was a diode laser, 810 nanometer. So subthreshold micropulse, how does it work? Subthreshold, we all know what is below the threshold power. And in micropulse laser, basically the laser energy is chopped off into smaller impulses when on time and off time. On time is the effective work of the laser on the retina, and off time allows the retinal tissues to cool down, so there is no heat buildup. When there is no heat buildup, there is no burn scar or there is no RPE damage. It's just stimulate the RPE to rejuvenate it and improve the function of the RPE. So this is my first case. This was at presentation at 3 months and at 6 months. At 6 months, the visual acuity was 6.9. This is the second case at 3 months and at 6 months. The third case, this was at presentation, and this is at 6 months. In this case, we can see the visual improvement is not that much, and we all know the reason why. There is RPE disturbances, incomplete resolution of the SRF, and hence the non-improvement of the vision. So for our study, we took total number of 25 patients with average duration of symptoms for 6 months. The response to treatment was measured by best corrected visual acuity and OCT scans. Fundus autofluorescence was done in all the patients before and after the laser to see any laser-induced RPE damage. The laser setting used was 125 micron spot size, 0.1 second duration, and a duty cycle of 5%. So how do we titrate the laser? We just do a full threshold burn outside the arcade, decrease the power by 50%, and then I did a high density treatment all over the diseased macula, just leaving the 500 micron of the center. So in the results, we can see there is 78% in the eye's subretinal resolution and decrease in CRT in 88% of the eyes. We can see here there is an anatomical improvement of almost 80% of the eyes, but the visual improvement is not that much, it's just 66%. And we feel that the reason was that we took the patient who had the disease for past 6 months. And of course, in those 6 months, there was a constant neurosensory detachment, hence the damage to the photoreceptors. If we compare it with an international study, they also found that in the cases where they implemented the laser earlier, there was marked improvement in the vision. And because this is a non-damaging laser, instead of waiting for the CSCR to resolve by itself in the observation period, we can apply this laser. And this is my published study in 2021 in Pakistan Journal of Ophthalmology. So in conclusion, okay, so there are some laser or limitations of this laser and the study. First of all, there is titration of the power. And also, because we can't see the laser spots, there is always a chance of over-treatment and under-treatment. But of course, we can always repeat the laser. And also, there is chances of a recurrence of the disease. In those cases, we can repeat this laser because it is not that damaging. In my study, out of 25 patients, there were 5 patients who had recurrent CSCR, but it was after 1 year. So we repeated the laser in those patients. In conclusion, it is a good option but we have to imply it earlier in the disease, before the permanent damage of the photoreceptors. Thank you.
Any questions?
Yes. We use the Iridex 810 nanometer. They have the option of micropulse and subthreshold. We just change the setting in that laser and we do that.
There is no special machine for that.
No, we just need the micropulse option in that. Yes, sir.
Yeah.
Yes. There is an option in the fundus autofluorescence and in the FFA. We can observe the marks of the laser, but for that we basically make the markers around the vessel that yes, in this area I have already implied the laser. Then we mark another vessel, just clinically. We can't say. That's why there is always a chance of under and over treatment. Thank you. Thank you.
So let me ask a question. Sorry, another question. We used to use photodynamic therapy when the dye is available, but now we couldn't find Visudyne, and therefore we couldn't. So the photodynamic therapy was an excellent result with chronic CSR patients. And I don't have experience with subthreshold, but have experienced some endpoint management treatment. The other one is like similar, but also some difference between subthreshold and endpoint managements. But my result is not really good. We have more than 40 cases, but the result is the success rate is less than 25%. So do you have an experience with these two treatments, with endpoint management and subthreshold? Yes. No. For CSR, not PDT. You mean to treatment of CSR, subthreshold comparing the endpoint management treatment. Another subthreshold type, like Pascal laser, has endpoint management. You don't have experience that one. Okay. So.
All right. So thank you, Dr. Mariam. We'll like to introduce our co-chair as well as next speaker, Dr. Irfan Karamat, on the AK kit for suprachoroidal injection.
Good evening, ladies and gentlemen. The topic today I would be discussing about is AK kit. It's a technique, or it's a separate kit with the help of which we can give suprachoroidal injection. My presentation layout would be that I would be discussing about the type of steroid injection we can use, type of syringe we are using in Pakistan, site of injection, and AK kit as an easy tool. It's just a background that the thickness of sclera varies from the cornea till optic nerve, and if you just look at this side, it's almost 0.8 millimeter from at the limbus and goes towards 1 millimeter when you go towards the optic nerve. This thickness varies when you move from the cornea, from the limbus towards the posterior pole, and the precise measurements is almost 0.7 millimeter to 0.8 millimeter at the 3.5 millimeter or to 4 millimeter from the limbus, where we usually inject intravitreal injections. Now coming back to my, this was just background knowledge, just for the sake of how I have designed a separate kit for suprachoroidal injection. We have in Pakistan we have been using steroids with the name of K-Cort, Lunacort, Triton, or Tysons. The difference between these four choices is that Tysons is a preservative free, and rest of the choices are with preservative. And it was being there was a thought that intravitreal steroid should be used. We should have a preservative free choice for that. There was a study published in 2012 which showed that there's no difference between if we use preservative-free or any steroid with preservative. So both choices are safe. And second, that we have almost we can inject 0.5, 0.1 ml from 4 to 12 milligram of steroid dose safely in intravitreal compartment. This is the dose we can use safely according to the study. The type of syringe we have available is 1 cc insulin syringe, 1 cc syringe from Braun company, and 1 cc disposable syringe. If you look at this syringe, this is the insulin syringe. The needle is quite long, and it can, if we usually do not use it for any intravitreal injections. This is Braun needle. The length of this needle is 8 millimeter, as it's been shown in the picture, and this is its platform, which is almost rather exactly 7 millimeter in length. So in total, it is almost 15 millimeter in length from the base. If you compare these two needles, there is a difference between the platform and the length of the needle. Usually when we give suprachoroidal injection, we trim a cannula, with the help of which we just leave a bare 0.7 to 0.8 mm of needle, and we use it for the suprachoroidal injection. And sometimes there's a chance of error that we can trim it a bit more or less, and which can lead to either intravitreal injection of steroid or in the subconjunctival space. What I designed was a small gadget with the name of AK kit. It has a body and a neck. The precise measurements are that it's just a bead which can cover the needle to some exact measurements. Like it's almost 9 millimeter of its body, and neck is almost 5.5 millimeter, which in total makes it almost but exact 14.5 millimeter in length. If we use a needle of 15 millimeter, we have a bare needle of 0.5 millimeter, which is almost its opening end, and that is what we need to which makes it safe as well. I'll show it in a video. It has a body, a neck, and within inside it has a metallic covering. So when we insert a needle inside, it doesn't touch this plastic part. It's made up of human grade plastic and Teflon as well. Once you are done with the steroid, take almost 0.1 millimeter of the dose, and you just take that bead and insert it over the needle. You give it some rotational movement so that it's fixed properly, and just 0.5 millimeter of the bare needle is outside the gadget, outside the AK kit, which makes it safe to inject suprachoroidal injection at 3.5 millimeter from the limbus. We conducted a study of 20 surgeons who used this AK kit, and we designed a performer which was based on the comfort level, its usefulness. This is the data from 20 different surgeons who used this gadget, and what we have seen that out of 20, 18 found it useful, and they came up with very mild complications like subconjunctival hemorrhage or leakage of steroid in a subconjunctival compartment. Otherwise, there was no there wasn't any grave complication in this. There was another study which in which I have studied safety factor, in which we have seen that whether there was any orbital or ocular inflammation or any process diplopia or any case of endophthalmitis. We studied 200 cases who had suprachoroidal injection with the help of AK kit, and none of them had any such complication except subconjunctival hemorrhage or leakage of steroid in subconjunctival area. Thank you. Sorry. We do. Was there any? Yes. Sure. Sure. This way. No. Actually, the exact size of the kit and the needle is there. You rotate just to make it sure that it's already at the end of the bevel, or sorry, or at the end of the platform. You just rotate it 3 to 4 times so that you're sure that there is no space between the end of the platform and the kit. There's no screw there. You don't need to.
Okay, but every time you rotate, it might change the length of the needle.
No.
Yes.
Okay.
And this the first. Second of all, are you sure that all of those needles are at the same length?
Yes.
I'm not talking about the design. The needles, as I practice in Syria, needles from the same patch have different sizes. Those from Chinese manufacturer. So I don't know. For BD, I think they are all the same lengths.
Yes.
But the Chinese surprised me that every needle at the same patch has a bit of microns change between the needles.
This gadget was meant for a Braun company, as BD is there. Braun is another. It's a very good company with a very standardized lens, and that makes it almost. Rather, that is a sure point that then all the needles are of the same size.
Have you measured about 20 or 30 needles to make sure that they are the same length?
We have done it multiple times because we were designing something new, and we designed that gadget for according to the needle or the company which is manufacturing that needle.
Because I was surprised when I practiced the suprachoroidal injection that each needle, especially the pivotal, not the same length. The pivotal is not the same among the same patch.
When you switch companies,
switch company. I'm talking about the Chinese manufacturer, the same patch, not switching companies. I'm talking about the same patch.
I think you mean that we need maybe compact system, not arrange like the needle and the others. Maybe compact system we may produce like company, I think Bausch & Lomb as a kind of suprachoroidal injection needle.
Yes, sir.
So I think he's right, because the turning or the force of compressions through the sclera may also can be changed the size, the length of the needles and therefore maybe better to make a compact system together everything and to do it for the injections.
Sir, if I get a minute, sir. We inject this injection at give this suprachoroidal injection at 3.5 millimeter from the limbus. At that point, the thickness is almost 0.75 or 0.8 millimeters. Sorry.
Yeah.
Now, what I designed is that the bare needle which comes out of that gadget is of 0.5 millimeter in length, which makes it safe that in the way that until you press it, you're not inside this at the suprachoroidal space. You have to press it for a bit. Second, about the platform or the number of rotations. There is no screw there. If you please, can you go back to my presentation? I've used, there was a multiple design of the needles. What I selected was a brawn needle. It has a platform which is smooth, and it has a smooth end. When you insert that gadget on that needle, it goes till the end. We give those rotations just to make sure that we are at the end of that at the end of that platform. I must have brought that with me, but it makes it, there's no screw or number of rotations doesn't matter much. The number of, we give rotation just to make sure that 0.5 millimeter of the needle is outside that AK kit. And until you press that that needle, you're not inside the suprachoroidal space. You are just in the sclera, which makes it safe. That is the reason that I make it a bit, the size is a bit lesser than the actual at suprachoroidal space.
While injecting, do you, by this technique, do you feel any kind of resistance?
A bit. That is the that resistance is basically because that I'm not exactly at the suprachoroidal space. I'm at almost sclera, at the border of sclera and suprachoroidal space, which makes me confident that I'm not inside in the intravitreal space. That pressure is just because that my needle is not that long. It's at the border of the sclera and the suprachoroidal space.
But if you go to the clear sight papers, you would notice that they insist on you feel no resistance while injecting, because you are entering an empty space. You are injecting 0.1 in a space which is 1 millimeter.
Yeah.
So you shouldn't feel any resistance. Any resistance, that's mean you are, as you mentioned, not in the suprachoroidal space. You are somewhere else. But
where else I could be? Where else there are three?
Somewhere between the sclera and the. That's why I asked you about the resistance.
Yeah, the resistance is just a normal or a simpler way to make it sure that I'm not in the intravitreal space. That small resistance just makes me sure that if I cannot inject in the sclera, can I inject in sclera? Can I inject in sclera?
Maybe somewhere between the sclera and suprachoroidal space. I cannot answer this, but I've injected about 1,000 injections of the suprachoroidal space since 2018, and whenever I feel resistance, then when I saw the papers of Clearsight, I follow up them, and they insisted you shouldn't have any resistance while injecting. And when I inject and I don't feel any resistance, I like the intravitreal injection, but you see no triamcinolone non-weight inside the or intravitreally. And sometimes when I want to be sure, I feel the iris a little bit dilated. That means the intraocular pressure has been raised because it's pushing on the wall of the suprachoroidal space.
That is normal. That is
okay. So the direction of beveled side of needle is important through the limbus or through the posterior pole.
So I keep it towards the limbus.
Sorry?
Towards the limbus.
Towards the limbus.
Yes.
Okay. Maybe
Sir,
microphone, because we have time for discussion.
It's a dependent space. It's a dependent space where whatever you inject in that space, it spreads. It doesn't. What I've been through the data, and whatever you inject in that space, it spreads
circumferentially through the posterior.
Circumferentially, not just towards the posterior pole. It spreads circumferentially. The direction of the needle, I don't know.
Doesn't matter, you mean?
In my personal experience, I've given hundreds of suprachoroidal injections.
Okay, good.
We learned this technique from Amin Marshi sitting here about 3 years ago when he came to Peshawar, and he gave us the full demonstration, and we saw various movies on the YouTube which he loaded. And I must say he's one of the pioneer of the suprachoroidal thing. You must watch his video as well, just for the experience sake.
But
and the other thing I wanted to ask you, the locally manufactured, the K-cot and all that, they are horrible. They're not effective. So which triamcinolone are you using? Because I don't have any good experience with the local manufacturing canacords injections that you're
Sir,
giving subchoroidal, to be honest with you.
we in Lahore, like in Mayo or LRBT, we use K-cot, Kenalog, K-cot, these steroids. Sir, we have good results. My presentation was not about the results. I might have shared that as well, but with that, those choices, we have very good results.
Okay, thank you. Dr. Muhammad Hasnain is here.
Thank you.
Thanks. Very good. Okay, I think you will speak about the same
Yeah,
topics. Please.
I started my work on the suprachoroidal injection after studying the articles of Mr. Amin Marashi, and I'm really delighted to have him here. Yeah. So it's a bit of modification. So I'm going to talk about the safety profile of the suprachoroidal
please,
injection.
Talk to microphone, please. Because
Without cannula sleep. Why suprachoroidal injections instead of the intravitreal injections? Because of certain risk factors involved with the intravitreal this injection of the triamcinolone, mainly IOP rise, cataract in the phakic eyes, visually disturbing floaters, retinal tears, detachment, vitreous hemorrhage, and endophthalmitis. Objective was to evaluate the safety of the new technique of the suprachoroidal injection of triamcinolone without the need of the cannula sleeve. It was a prospective study with 70 cases were enrolled, and the preoperative visual acuity, intraocular pressure, and the CMT were recorded. Inclusion criteria were diabetic macroedema patient, those which were not resolved in with three consecutive intravitreal injection of bevacizumab with CMT and OCT 250 microns or greater, and less than 10% reduction in the CMT from the baseline after three consecutive injections. Well, those patients having age less than 18 years, ocular hypertension, glaucoma, and pregnancy were excluded. This is how I measured 1 millimeter of the tip of the needle. I used 30 gauge insulin needle from the BD, and it was 1 millimeter tip was bent with the needle holder, and it was then measured on the caliper to be 1 millimeter. And after the measurement, I selected the quadrant and marking at the 4 millimeter in phakic eye and 3.5 millimeter in pseudophakic. I injected it, keeping an eye on the glow that it has gone into the suprachoroidal space. After that, I pinched it with the corneal forceps to prevent the revegetation if there's any. The result, 44 patients were male, 26 were females, mean age was 50.8 years. Mean IP pre-injection 12.76, after injection at 5 minutes 14.8 millimeter of mercury, after 30 minutes 14.5, after 1 hour 14.6, after 2 hours 14.7, after 1 week 14.7, after 1 month 12.98, after 3 months 12.83 millimeter of mercury. Well, the data was analyzed with SPSS, where t-test was applied, and there was statistically significant difference between the pre-injection IUP and post-injection IUP after 5 minutes, 30 minutes, 1 hour, and 2 hours. But there was no statistically significant difference between the pre-injection IUP and post-injection IUP after 1 week, 1 month, and 3 months. This is the distribution of the pre-injection IUP after 5 minutes, 30 minutes. Some patients have showing the rise of IUP after 1 hour and 2 hours. After 2 hours, those patients in which the IUP was high, they were given systemic estrazolamide, beta blockers, and lateral plus analog, and they were followed after 1 week. After 1 week, most of the patients have settled, but there were 2 patients in which the IUP rose after 1 week. These patients were again given systemic estrazolamide, beta blockers, and lateral plus analog, and they came with normal IUP. And after 1 month, their systemic treatment was stopped, and after 3 months, their beta blockers and the other lateral plus analog were also stopped. Well, if we compare it with other studies, other studies also shows the rise of IUP in certain patients, like the health study in which the 2 patients showed the rise of IUP, while Avadesh Ali has shown none, while Harun Tayyib has also reported a patient in IUP rose from the 19 to 24 millimeter of mercury at 1 month follow-up. Conjunctival hemorrhage occurred in 9 cases, spillover into AC in 1 case, regurgitation of triamcinolone in 3 cases, while none of the patient got intravitreal leakage of triamcinolone or trauma to the crystalline lens or vitreous hemorrhage, while endophthalmitis was noted in 1 case. How conjunctival hemorrhage occurred? Usually when we pinch the conjunctiva with the corneal forceps or we put in the needle, sometimes it tears the conjunctiva. So be careful when we pinch the conjunctiva. Other option was to use some indenter. This is the other option in which we don't pinch, we rather just use indenter or the backside of the dialer to prevent the regurgitation of triamcinolone. We just rub it to prevent the regurgitation of triamcinolone. Although there is no frank bleed, but minor ooze can still happen. So this technique does not require the cannula sleeve, is cost effective and is well tolerated, and apart from the transient increase in IUP immediately after injection, no significant adverse effect occur. The place of my work. Thank you very much.
Any further discussion? So please, microphone. Yeah.
I really liked it, but I disagree with the point of putting a indenter or applicator. This space is very fragile. If you press on it, sometimes it can burst and open into the intravitreal space. So if it's give a little bit of regurg, it's okay. Nothing will happen. It's a bit of a regurg, no problems. Even with the clear sight injectors, you might have some kind of regurg. It's okay. It still gives you results. It doesn't eliminate the results you had.
Well, thank you. Strange enough, we have injected, I think, more than 100 of the cases, and not even a single case in which it went into the vitreous cavity. Okay. Okay. Yeah. Don't. Okay. Yeah.
Should I think the
Okay.
So
Thank you, please. Yeah.
let me ask you a question. So is it possible to bend needle like 1 millimeters in all syringe? So the predictability of your technique to bending the needles 1 millimeters, then inject in suprachoroidal space, I think it's I have no experience, but I don't think that it's possible to bend needle 1 millimeter length in all syringe in all needles. Is possible?
Uh, I have just after the bend I have checked it on the caliper that I
check
have,
always
yeah
after.
I always check that before injection I always check that the bent portion is 1 millimeter. If suppose by accidentally I have bent more than that, I will discard the needle and use another needle.
Okay. Could you
Yeah, the bevel length is less than 1 millimeter. One, yeah, 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 yeah. It will regurgitate back. जी 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 नहीं नहीं जो 30 गेज क्या है sir the one which is of the 30 gauge, it's the 1 millimeter, it's very small. There is always a portion of the solid which remains outside, so there is less chance.
So you inject 4 millimeters?
4 millimeter in the phakic and 3.5 in the pseudophakic.
Okay. Any question?
Right. So we'll move on to the next speaker, Dr. Amin Marashi, on new applications of microsecond laser.
So I have no financial interest in this presentation. Let's review the old indications or the typical indications, which are for central serous chorioretinopathy, as it gained popularity when as vitroprophin is not needed and we have a global shortage of it. It is safe and effective if it's done properly and correctly. Subthreshold microsecond laser is a cheap procedure. It doesn't cost. It's non-invasive and it doesn't cost the physician and the doctors the same amount as the PDT. And subthreshold microsecond laser requires a very short term of learning curve, especially for those who are practicing the focal and grid laser. No need for an invasive imaging guides as fundus fluorescein angiography or ICG. OCT or fundus autofluorescence for CSCR is more than enough. And it can be repeated safely. There's an argument that after treating those patients with subthreshold microsecond laser, the subretinal fluids will recur. Okay, but if it can be repeated safely, no problems at all. We always repeat injections, so why not repeating the laser? There is a couple of evidence-based medicine, which is not a highest level of recommendation, but this is what we have. It's the neurosensory detachment results between 67% up to 100%, and the recurrence is up to 23% of those cases. So it's not bad in terms of its results. There are multiple techniques and parameters. For me, personally, I go with the titration. I go to a non-edematous area. I do several applications with a 600 milliwatt, but the duty cycle here is 5%, which is 100 microseconds is on and 1900 microseconds are off. So I do not generate heat on the RPE to burn the photoreceptors, and the duration interval is 0.2 seconds. So if I achieved a threshold reaction, which is a bit changing of the retinal tissue, not a retinal burn, then I reduce that into half, which is here 300 milliwatt. Well, and of course on the 5% duty cycle. So I tend to treat all the area of subretinal fluids, and if I was entertained with the fundus fluorescein angiography, I would be more generous on the area of the leaking. So this is a case. She's the sister of my best friend. She's an optometrist. She's Vision 2032 and came to me with the reduced vision. Can you restart the video here, please? Can you restart the video? Showing a typical leak of smokestack. It doesn't work, so nothing fancy. It only shows me the area of the smokestack and the areas of PED. So here we have subretinal fluids, we have the double layer sign with PED and hyperreflective Brooks membrane, we have the thickened choroid with dilated halars and thickened elongated photoreceptors and outer segments. And this is her after the treatment. She regained vision 2020 again within I guess it was 1 month, within 1 month. And what about diabetic macular edema? Well, it is again safe and effective, it's cheap, and it can require shorter learning curve. No need for invasive investigations such as fundus fluorescein angiography, as OCT is more than enough, and it can be repeated safely. But please pay attention that micropulse laser is being overhyped, as it will substitute the injection. It will work as the mainstay treatment. This is not true. I've been practicing it since 2015, and it works only in mild macular edemas or non-central edemas. It will give us stabilization, not more than that. So there are also a couple of studies I'm showing here. Again, it's not the highest level of recommendation. And I asked myself a question: can we improve the subthreshold laser? Can we utilize it differently? Well, what I did is a hyperthreshold laser, a technique that I invented. I treat the leaking microaneurysms with a threshold laser using the microsecond technology. Then I treat the whole area of the edema with subthreshold microsecond laser. Let me show you how. I go to the leaking microaneurysms using the fundus fluorescein angiography, locating the leaking microaneurysms, and I use these settings, which I achieve this threshold. It might be 700 microwatts, it could be 600 or 500, depends on the patient pigmentation. Let's say 600 microwatts, but please pay attention, it's on the microsecond laser on. It's 5% only. So after treating the leaking microaneurysms, I switch to subthreshold by reducing it to half, and I treat all the area of the edema as defined by the OCT. So let me show you an example. This is non-central diabetic macular edema. That I treated the threshold with the threshold the areas of leaking microaneurysms, and then I treat the area of the edema as defined by the OCT, of course, by applying the laser spots in a painting fashion, leaving no spaces between the laser spots. Of course, here I don't see any kind of reaction while doing the subthreshold. So let's see how the retina behaved. So I just wanted to show you in this example how the retinal burn will appear and how the threshold will appear, okay, and how it behaved after 24 weeks of follow-up. There is a very minimal scar here. Barely there is no scar at all with this technique. Let's I treated about 12 eyes, and I had a reduction of thickness from 336 to 264. Please pay attention. I didn't go above the 400. I didn't push the limitation of this technology. It's a limited technology. It can help in certain patients, and this is the OCT, how it behaved during pre and 4 weeks post the HTL laser, and 24 weeks after the laser, how it I managed to reduce the macular thickness. But I didn't
achieve the full resolution of the intraretinal cystic changes. And another thing that I learned from Dr. Barbara Parolini once we was discussing, and I told her, what do you do with the dome-shaped maculopathy? And she is very bright surgeon for high myopia, and she told me, I do micropulse laser. I told her, how come? She told me, why not? Try it and you will find it very good. She uses the yellow laser, I use the green laser. So this is a patient that I was following up. This is at the presentation. This is after 6 months. This is after 1 year, and she had a vision about 2032, I get as much as I remember. And after the treatment with the 3 months, with a microsecond laser, I with the same settings I showed you exactly in the CSCR, and she improved vision to 2025. But I have still a bit of subretinal fluids, but the patient has a very reduction of metamorphopsia and improved vision. And as always, we are treating a patient, not an OCT. The main thing that she improved vision and quality of life. Maybe within more follow-up, more than 3 months, it will reduce the whole subretinal fluid. Thank you very much, and sorry for being a bit long.
Any questions?
Any questions?
Excuse me, sir. Yeah, I do the subthreshold laser in the patients of DME. The technique that I use is that I treat the microaneurysm with the threshold laser, not in the micropulse mode. The full threshold laser, the conventional laser, yellow.
Focal laser.
Focal, yeah.
Okay, so you can do it with the yellow laser because it's targeting the oxyhemoglobin, so
Yeah.
it's a bit safer than the green laser, which targets the melanin first, then the oxyhemoglobin.
Yeah, and then for this all over the area of the edema, I do the subthreshold micropulse laser, and that is also working very well for me.
The main difference here that if when you use the threshold laser, you reduce, as I showed you, the scar. So I
Yes.
intentionally did a burn to show it how to differentiate between burn and the threshold and how the retina will behave after
Yes.
24 weeks of follow-up.
Yes.
So with the threshold, you might get scar, but with the microsecond, as you're chopping the laser pulse, you will not increase the heat of the
Yes.
RPE until you do a complete burn. That's only difference, not
Yes.
more.
Yes.
Could you please the microphone, please?
For the trainees in the audience, would you like to tell them how do you record which area you've treated? Do you make any photographic record using blue peak autofluorescence, fundus autofluorescence, which area you've treated? Do you give contiguous burns? And does it matter if you give contiguous burns and 3 months later you treat over them once again?
With the microsecond laser. First, I am not entertained with the fundus autofluorescence, but if you have it, yes, you are correct. Fundus autofluorescence is the best to detect if you induced a laser burn or if you didn't do it correctly. Second, I do a painting fashion, no edema less than 500 laser applications. So I cover the area and I repeat and I repeat and I repeat. And if there are no scars and you had to repeat it, you can repeat it within 2 months. It's no problems at all.
And finally, how do you feel about treating the center of the umbo?
I try to avoid it. I do not go inside. But if I went for some reason, the patient moved his eye, I don't feel afraid like with a conventional laser. If it happened with a conventional laser, I might not sleep for weeks after that. But with this, I know I sleep, but I don't target it. No, I do not target it.
Actually, it doesn't matter even if it falls on the center of the umbo. Yeah, you're right.
Next speaker. Thank you. Next speaker is Dr. Abdul Hannan, suprachoroidal injection review.
Assalamu alaikum, ladies and gentlemen. Topic of my research today is just a review of all the landmark trials that are already been published for suprachoroidal injections only. This is a subject of great interest these days in Pakistan because we are getting into a practice of suprachoroidal injections, and as we should also know that what already data is available on what things turn out to be. So the theory of suprachoroidal injection came from the fact that it is a space which can be or potentially can be used for drug delivery in choroid, and particularly for choroid and retina, where the concentration is much more higher for the target tissue as compared to the other forms that were previously being used, such as the intravitreal and the topical and the subtenon space. So in suprachoroidal space, the treatment of both choroidal and retinal pathologies work in theory more effectively and in animal models more effectively for any therapeutic, gene therapy, and for oncology purposes. So it maximizes the delivery to the posterior segment, particularly to the choroid and retina, as compared to the intravitreal dose, and it limits the effectiveness of all these drugs and any treatment modality they're using to that area only, and limits its effects on the interior segment. This makes it a potential competent as compared to the other modalities which are already available. So the first trial, I've divided the trials into three major forms of treatment. One is the uveitic macular edema, the other one is diabetic macular edema, and the last is RVO related macular edema. The landmark trial for uveitic macular edema was the Peachtree trial, which is one of the biggest and the largest trial in this segment. The primary endpoint was best corrected visual acuity gain of 15 letters, and the secondary endpoint was control of central subfield thickness. And both of them proved major results from 46.9% as compared to 15% in control group. This was a trial which actually led it getting the FDA approval for the use in the uveitic macular edema through ZPRE. The other landmark trial was the Dogwood trial. In Dogwood trial, the primary endpoint was exactly the opposite of the Peachtree trial, the central subfield thickness reduction, and the secondary outcome was the increase in the best corrected visual acuity. And both of these proved out to be, much better as compared to the control group. Now, the macular edema, the type of edema we use this suprachoroidal injection most in Pakistan. So we'll be interested in these trials. The biggest trial is the TIBE trial. In TIBE trial, naive patients, 71 treatment naive patients were used, and the comparison was not exactly between suprachoroidal injection and any other form of intravitreal injection. It was between the combination of suprachoroidal Kenacort with intravitreal aflibercept versus aflibercept alone. So the results of this trial cannot totally, make a suprachoroidal injection a hero out of all this, but we, still have some data to go along with it. The primary endpoint was best corrected visual acuity, and the results were not that differential. The gain of letters from this was not very significant amongst the two groups, but the secondary outcomes showed a lot better results. The thickness of central subfield from 2 to 7 as compared to the 176 in aflibercept alone, and the other secondary outcomes were fewer number of injection needed. Those were also better in the combination group. The IOP that now I'll come to the controversial part, where the combination group showed more cases of cataract, more cases of IOP increase, which actually needed anti-glaucoma therapy. So as it was showing promise on one side, the complications were also showing up on the other side. The other trial is the HULK trial. In HULK trial, the same best corrected visual acuity and central subfield thickness were used, but the two groups being compared were again the combination group versus aflibercept alone. So in diabetic macular edema, separate suprachoroidal injection has not been trialed in a very big trial as yet. So it was still a combination versus aflibercept. Proved again to be better for both best corrected visual acuity and central subfield thickness decrease. The other major trials were for the RVO related macular edema. Theirs were Tanzanite and Sapphire trial. The Tanzanite trial was again a combination versus IVA, again not separately comparing aflibercept versus suprachoroidal Kenacort. But the primary outcome was number of retreatment injections, not the best corrected visual acuity, not the decrease of subfield thickness. Best corrected visual acuity was a secondary. Both of these primary and secondary outcomes proved to be better for the combination group, where less number of injections were required, and the best corrected visual acuity was again very good. Now coming to the Sapphire trial. Sapphire trial is the only major trial amongst all the trials of suprachoroidal canal cord which ended after 2 months because of no apparent change between the two groups, where the combination group was being compared to the aflibercept alone. So this trial was terminated. So this was the only group which did took the medal away from the combination group as compared to the others. But this was only due to the IOP data is immature, so I won't be talking about it much. I still need more work to compile all the available data in the literature regarding the IUP increase and the complication data on the suprachoroidal injection, so I won't be talking about this. The work in Pakistan is, one of the articles is from Dr. Irfan Karamat, and the other article is from Dr. Haroon Tayyib. This article was, the research was conducted in 2018 and the better half of 2019 and published in 2020. In this, the primary outcome was against center subfield thickness decrease and best corrected visual acuity was a secondary outcome. Both did prove to be, much better for the case of suprachoroidal injection as compared to the control group. What does the future hold for this form of, injection technique? The two available researches that have been tried out were on adenoviral vector 8, through which they have tried to inject antibody fragment into the suprachoroidal space and try to control choroidal neovascularization much better as compared to intravitreal route. And the other is suprachoroidal delivery of exitinib, a tyrokinase inhibitor, for its use in choroidal melanoma. It proved out to be one of the potential ways in which you can decrease the size of choroidal melanoma and then treat it through other modalities. So the only FDA approved or the only approved instrument that is available for suprachoroidal injection is by Clearside, ZPRI. Their production and the length of the needle, they are all standardized. Their method is standardized. They have a large trial on its backing, so you can read those trials. You can know the methods they've used, the precautions they have set, the complications they have had. But this is currently not available in Pakistan because, as per my knowledge, it got its FDA approval back in 2021 October. So it's yet to come in Pakistan and we to use it. The suprachoroidal injection needles that we use are actually made from India, and we buy them and then we use them in Pakistan. But due to the standardized size of the needle that is protruding out, we usually end up either injecting into the sclera or we sometimes get into the suprachoroidal space as well. So we are still not sure, how to standardize this process. We have tried making them our own as presented by Dr. Irfan as well and Dr. Hasnan as well, but it did not turn out to be that well because the margin of error of 0.8 to 0.5 is too less. And how much pressure are you going to imply? Although all the data that I have read on Clearside ZPRI, they do encourage the surgeons to apply a little dimple pressure. As is seen as well in the diagram, they do tell to apply the little pressure. But I don't know what kind of mechanism there is inside which compensates for that exact thickness of 0.8. But what have we tried to make in our, manually with our setup and limited resources, standardizing that 0.8 millimeter, sweet spot is always has been difficulty for us. So the one thing that I've, learned from Dr. Marashi is that, the pressure thing is always a bad sign. So you should go back, reassess, and then use another needle for it. That's what I've only come up with. So that's the end of my presentation. Thank you so much.
Thank you. So, any discussion, any question? I think we already discussed a lot about suprachoroidal injections. So I think we should conclude our session today, and it was our last speakers. I would like to thank all speakers and audience and my co-chairs for this very good presentation and discussion, and conclude and see you in our next session somewhere. Okay, thank you.
Thank you.